Jack. How are you? And you like to bring on these amazing experts to provide such value for men because that's your goal to serve men, isn't it?
Absolutely, Neil. And, John had such a resounding response after his last appearance here on the Ultimate Men's Movement. We did our last talk about shoulders and shoulder health, and I think we got good response to that. And I think I personally also liked the fact that we were able to merge in, the orthopedic carpentry along with some discussion of wellness, longevity, health versus illness. Um, so we decided to go with another one. Today we're going to be discussing knee arthritis predominantly, but also the effects of weight, the effects of high BMI, metabolic disease, and testosterone in that development of knee pain and knee arthritis, which may require knee replacement. And I think there's definitely a lot of interconnecting weight management and knee replacement conversations that we can have. So, welcome back, John. Thank you so much for taking your vacation time to spend a few minutes with us here on the movement.
Anything for you, Jack. Resounding response, notwithstanding, anything for you.
You are my best man, John. I don't think we mentioned that the last time. So,
Yes,
but you are up vacationing in on Lake Erie, correct?
that's correct, Jack.
Good.
Just a little west of Ashtabula, Ohio, going towards Geneva on the Lake. You're familiar with that?
Mhm.
Yeah, you're not far from me in Mentor, Ohio at all. So, Mentor on the lake. So, we're not far at all right now.
Yes, I can
Okay.
sense that. It's a close, vibe going on here.
All right, John. So let's get started. Let's talk about knees, and I think we're going to eventually um, go into knee replacement. But so you are a sports guy. You do cover everything from, knee scopes, ACL reconstructions. I don't know if you do multi-ligament reconstructions anymore, but um, through the process of degenerative knee arthritis and total knees. Now, what are you seeing in your practice with regards to the knee and knee pathology?
I think, Jack, the topic of this conversation and this podcast is very applicable to what you're referring to with the I won't say older, but I'd say middle-aged male who is a little bit overweight. Maybe I'm talking about a 45 to 60-year-old who tears their meniscus, has a little bit of arthritis. You scope their knee, you know, not the worst knee in the world. Not, oh my God, this guy needs a knee replacement, but they just do well afterwards. They sort of limp a little bit. They're a little swollen. They don't get better as much as they wanted to, and that's a very unhappy subset of patients. Unfortunately, for all of us who do this for a living, a very common subset of patients, and
Hmm.
how to make that patient better, for lack of a better term.
Right.
And like you mentioned, weight loss, um, body optimization, body fat optimization um, can make someone not have a less degenerative knee, but certainly feel better.
Yeah.
And that's sort of what we're in the business of doing.
Yeah, John, I'm not sure how much we talked about this, but I had a very intense exposure to the idea of generalized inflammatory arthritis during the COVID, during the
Mm-hmm.
pandemic. 2 months after I believe it was related to the vaccine. During all of COVID, I worked every day. I never once had symptoms of a flu, of COVID, of anything. I never tested positive, but I had my first vaccine in January, had my second vaccine in February, and April, I went golfing one day and I came, after golfing, my right knee, which was the knee that I've had, you operated on my right knee one time. I had a knee
And I've seen
replacement.
you golf, so I can understand,
My
injuries
golf
coming from.
swing is my golf swing is not conducive to a bad knee. Um, but anyways, you always got to start, John, don't you? But like after golfing, I started, my knee started swelling. Like I started getting an effusion. And at some point I told my PA, I'm like, this knee is going systemic for me. and I was like, I was a little perplexed, and I'm like, my kids were coming in, and I drained my knee. She even injected my knee with some cortisone, and I was feeling systemically, I was feeling pretty bad. And I asked her to, she put me on a Medrol dose pack. Like, I'm not a big fan of steroids, but I went on a dose pack, and make a long story short, eventually I ended on, systemic steroids, oral steroids for about 6 to 8 months. Like, it went completely systemic. I couldn't lift my shoulder to shave my head. I couldn't get out of bed. I used to have to keep my arms at the side because I couldn't lift to even push from the bed. So I would like roll to the side and do one of those log roll maneuvers. Um, my SED rate at some, I went through a rheumatologic workup. My SED rate was 86, which is extremely high. We were always,
That rate's an inflammatory marker for those that don't
yeah,
know.
my CRP was elevated. I forget what that number was, but the SED rate being 86, I remember from our training in school, 15 is maybe the top normal for SED rate.
Right.
And if you make it to 100, what we were taught or what often seen was that this is someone who had a very um, systemic, deep-seated, metastatic cancer.
Acute infection or a severe inflammatory reaction.
Right,
Yeah.
right. Osteomyelitis, something deep. So, like I said, I was at 86, which was impressive, and I could feel it. Like I was sick. I was systemically sick, and a lot of that went into some of my considerations for options for careers. I'm trying to fix shoulders and knees and hips, um, and I'm having my own shoulder pain. So the thing that amazed me about it is that it was the inflammation in my body which caused the knee pain. Not, we typically were more mechanically oriented where you have a bad knee, you have an injury, it creates inflammation, you have knee pain. But for me, it ended up being my whole body. And like I said, it was this inflammatory reaction to
Or just
whatever it
manifested in
was.
you as knee and shoulder pain, but it was total systemic inflammation.
Correct, correct. Um, and it comes into play, I think, with a lot of these, I would look at the patients that we have as knee replacement patients. You can put them into two broad categories, obese versus non-obese. And a lot of times you'll see that guy who still has good muscle mass. He's not overly obese, former athlete or former blue collar worker, who's got the bowed legs. He's got really bad knees, but he may or may not have knee pain. And then you get some of these patients that are a little more obese, who have, not horrible looking knees on x-rays, but a lot of pain. And I think that's where
That's what I was talking about. Right.
yeah, I'm
That
getting to my
second
point.
subset is tough.
Yeah, getting my point of this subset of patients that are morbidly obese, they've got BMIs 30 to 40. Um, and the knees aren't necessarily that bad. They didn't necessarily have any injury, but it is a systemic disease, really, that's manifesting as some of their knee pain. And what do you when you see those patients? Some of them they may or may not qualify for surgery because of their BMI. Um, you'd like them to lose weight because you don't want to replace the knee in someone who is obese. The heavier you are and the younger you are, the more likely you are to result in loosening and revision. What are your thoughts on all that?
My thoughts are right along with yours, and I would tell you, like I stated earlier, our job is to make people better, right? We can replace knees and have the most beautiful X-ray in the world, and good looking objective findings, good incisions and things like that. But some people don't get better because you didn't
Hmm.
treat the underlying problem, which sometimes is not the arthritis; it's the inflammatory response. And so, yes, you have to figure out what is causing the symptoms, whether it be worn out joint, bone on bone arthritis, or is it that overall inflammatory situation going on that's not going to get better with surgical treatment?
Hmm.
No, it's interesting, guys. I struggled with knee pain young. I was a high school, college basketball player, tall, lanky, really didn't work on muscles. So I probably, if I would have done more I started lifting after pro wrestling, starting to make my journey in pro wrestling from basketball when I was only like 220 pounds. So I lifted some, but I always had knee pain and I tendonitis in both knees really young. What is that? How does that manifest?
Go ahead, take this one, John.
Jack.
You're the sports guy.
Okay, I would take that. Yeah, uh, multifactorial. A lot of it is height weight discrepancy. The tendon length that you have being you're 6'10" or something like that. You say you're 6'9".
6'10,
Um,
6'10, yeah.
and yeah, the
So I was
tendon
six
length.
nine then when I was in high school, and I went through
Right.
knee pain probably from 6'6" to 6'9", and my knee pain probably didn't go away ever till I stopped playing basketball.
So some of it is the classic growing pains where you have a growth plate that's open and the physis gets inflammatory and irritated, the growth plate. Some of that is from the stress of long tendon length. Orthopedics is applied physics, right? So you have lever arms and pull, and if you're not strong enough, if the strength isn't there to equal the lever arm that's being pulled on by your height and length, then you get pain associated with it.
Absolutely.
It's
And it's
it's
amazing when you
have to have the
treat those.
strength to go with the size.
Yeah, and what I found too is that when you treat a lot of those young kids that are going through growth spurts, they come in with these vagues, it's the old Osgood Slaughter's disease of the
Right.
knees, and you see those
Apophysitis.
kids. Pardon me?
Apophysitis. Severs,
Correct.
Osgood Schlatters.
Yeah. But you see these kids in the office, and these are healthy kids, they're athletes. And when I see them, a lot of times I'll ask them to touch their toes. And it's amazing to me how inflexible they are because I
Right.
say like their feet have grown away from their fingers. As they're growing so fast, the bones have lengthened, but the tendons haven't quite caught up with the bones. So they're surprisingly tight hamstrings, tight quad tendons. So that's usually a stretching thing, and not necessarily any issues with the joint per se. Just it's
Right.
the surrounding tissues from it. But the population, like you said, the more difficult that tweener group, that group that's in no man's land. They're too young for they don't really need a knee scope or they've got a little bit of early arthritis. Um, They've got maybe a little bit of meniscal damage, a little bit of just wear and tear in the knee, um, but they're not quite ready for a knee replacement. They're a little overweight, they're a little out of shape. That's the wheelhouse of the men's clinic. The guys that you're trying to get more longevity on their knees and improvement. And what do you do with those guys? Are you doing cortisone? I mean, that's a lot of the hallmark, but
Yeah. Frankly, Jack, your clinic is right in the you said the wheelhouse is in the wheelhouse for that patient for a number of reasons. Some of it is they're just out of shape and they're unhappy, right? They're unhappy. They smoke too much, they drink too much, they don't sleep enough, they hate their job, they're unhappy, and they manifest some of this stuff as pain, right? Joint pain, this or that aches. And if you could make them happier, not which healthier equals happier, right? So you can make them healthier from a weight standpoint, from an exercise standpoint, stop smoking, don't drink so much, sleep better, which is huge. Suddenly their knee pain isn't so bad.
right.
That's a lot of it, honestly. If you
Mhm.
can cure those things without even touching their knee, they get better,
Right.
markedly better. Short of an obvious structural pathology, a big fat meniscus tear, bone and bone arthritis, those things that we dig into as orthopedic surgeons with knife and fork, right? But it's those middle ones that you're talking about. They're just unhappy
Right.
people with lots of things going on.
And if you send any of these guys for an MRI, guess what? It's going to show something.
Something. It's going to show
Something.
something, and
You're going to
and
the
they want to
MRI
hang their hat
report,
on something.
right. The MRI report is going to come back partial tear, posterior horn, medial meniscus, some degenerative
Yes,
partial tearing of the ACL. Like everything is just frayed and tattered, but there's no proof that any of it is
causes their
causing
symptoms.
is causing their symptoms. So you could, oh yeah, you have a tear. As soon as someone sees a tear on the MRI report, oh, you better fix that tear. But once again, if you refer to that tear as just some fraying or degeneration, some softening, there's different words that can be used. They're micro tears. They may
Right.
just be, they may be intrameniscal, they don't come all the way through. So there's definitely a lot of, and you can scope those people all day long and they're going to come back, they're still miserable. And then they
They're
hate
not going to get
you
better.
for
They're
their
not going to get
misery.
better.
Right.
Well, Neil, you can attest to this, not personally, but just in general. People want an easy fix.
Right.
My knee has its hair. You, as a surgeon, scope me, fix me, then I'll be better. Well, sir, you need to lose 20 pounds. You need to sleep better. You need to do what's a lot of work. I don't know if I want to do all those things.
That's the
I'd rather
mistake
have
is
you
that,
fix it.
right. Our jobs like marketing, overnight, I'm going to get all these sales. No, it's a process. Same
Yes.
thing when I talk about what you do. Okay, doc, you're going to put me under the knife and I'm good to go.
I'm going
No,
to
you're
be
going to have to
cured.
do rehab. You're going to have to put time in and you have to make sure you don't screw it up again
Yeah.
Yes.
because you could re-injure it. You could re-aggravate it. It goes back to, I guess, the people you guys see, your patients. Some of them really want to take action. Some of them don't. And that can become debilitating in the medical field.
Hmm. And here's, and then, like you say, John, I mean, you're right. This is in a lot of ways a perfect patient for something non-surgical. You don't necessarily want to be in an orthopedist office for that, because if you're in an orthopedist office long enough, and if you go to another orthopedist and another orthopedist and
Someone's going to
another
operate on you.
orthopedist, eventually someone's going to operate on you. Just
Right.
it's just
Yep.
the reality of it. You'll find
That's the
someone
way
that would be
the business
willing.
works. That's how you make money, right?
Yeah.
Right.
And,
A surgeon
it's
operates,
it's a
yes.
coin
Yes.
toss. Certain percentage of the time it's going to work, certain percentage it's not. But, so then, the idea of, the excess fat and, let's get into, said testosterone for me, when I went through my episode, I was not on testosterone. I had been on it before, but then I stopped it. Um, but I knew at the time that, testosterone is a good anti-inflammatory. Not only is it a good anti-inflammatory, it's all, I mean, it's, evolutionarily, if you look at it, if men are out there in battles, they're constantly getting wounds and injuries and this and that. And their higher testosterone may help heal some of those things by reducing the inflammation. Um, but also the way that it affects fat, especially visceral fat. If you can get some of these guys to lose some weight, to gain some muscle mass, to have more support and strength around their knee, to be able to walk downstairs without wobbling, without being weak, to be able to kneel down to pick up your socks without, having aches and pains. Um, Something as simple as that may help your knees. It's not what you would necessarily think of as a first line, but there certainly is a lot of improvement with that. And I'm at the point now, I mean, it took me a good year, a good solid year to get through all that inflammation, and I still had some tightness in a few of my joints. My finger wouldn't go down all the way, um, and it was disruptive. I did one PRP injection in my knee, which did seem to help, and that's one of those, same as cortisone. It may or may not work. It may or may not be doing anything, but for me, it was worth it. I had a PRP injection. And then recently I've been on some supplements which really treat a lot of the inflammation. And I'd say in the last 4 or 5 months, the anti-inflammatory, it's with the company LifeVantage. It's a product called Tri-Synergizer, and it's basically a systemic anti-inflammatory. It stimulates NRF1, NRF2, NAD. It helps with a lot of this revitalization. And I've also mixed it with some collagen, which I think is important for all those things that we talked about. You need some collagen for repair and for regeneration. Um, so you're right. It was,
For those wrinkles on your forehead, Jack, you got to do something about those wrinkles on your forehead too. A little collagen.
I've always had those. That's just that's because I'm always concerned and worried. That's my worry
Oh,
lines there. Yeah. But you can do injections, that kind of stuff. My point being that if you look at my knees, because I had an ACL when I was in college, and I had a second surgery after that in Pittsburgh for stiffness, and then you did my third surgery um, for a degenerative meniscal tear. Um, but if you look at my knees right now, you put those up on an X-ray box or a computer screen, any orthopedic surgeon in the world is going to say that guy needs a knee replacement. But guess what?
yes.
I've got no knee pain, minimal to no knee pain.
Wow.
That's
That can be
amazing.
huge for athletes. Wouldn't you agree, John? Like, especially the ones like me dealing with it when I was 16 and 17. If I wouldn't have that knee painting, who knows where I'd be playing?
Right. Well, yeah, sure we do. NBA, baby.
Yeah.
That's who we'd be playing.
Yeah. So, so it's, the knee replacement is a great surgery. There's
Right.
no doubt about it. But this is one thing that I could maybe be on the side of some of the insurance companies. You do need to go through a process of non-surgical care before you jump into a knee replacement. What do you tell your patients on when is it time? When is it time to get a knee replacement in your hands, in your practice?
So joint replacements in my practice are based on several factors. You have to have the structural pathology. You have to have the bone-on-bone arthritis, number one. You have to have a motivated patient who's willing to understand what it takes to get through a joint replacement, not only the surgery itself, but the rehab afterwards. And you have to be able to match up the findings on x-ray with the patient's complaints, because sometimes they don't quite match up, and that it's always a red flag. If where they hurt doesn't match where the x-ray says they should hurt, or
Mm-hmm.
how they hurt doesn't quite match up, right? You get some of those patients with the x-rays that aren't quite that bad, and oh my God, the pain's out of proportion to what you see. And we've all been fooled, Jack, over the years. You operate on that guy because they come back and they come back, and you fall for it, right? Say, okay, we're going to do that. And then afterwards, oh my God, they do terrible and their pain's not better. And it's worse now. And like, oh my God.
Especially a lot
You
of these
hate
guys
up.
who have, I mean, I've done that in my practice where you take a younger guy and you're like, look at this guy's x-rays. What's your diagnosis on this lady's x-rays? What's your diagnosis? She's like, oh, she needs a total knee. And I'm like, well, the finger says that she's got patellar tendonitis. You know what I mean? Like you touch the old this high-tech tool right here, you know.
Right, right. Examine the patient. All else
This
fails,
high-tech
examine the patient.
tool, which is attached to this incredibly refined
High-tech.
software up here, So you got the hardware and the software. That's kind of how we grew up doing orthopedics. But if you look at an X-ray, you look at a bone scan, you look at and you're right. If your findings, if the finger doesn't correlate with the high-tech findings, you're going to get burned and the patient will be harmed. So you're right. It's the correlation of that. What do you do with your patients? Say you got a patient that's, got a BMI of 40, 41, and you do think they need a knee replacement. That's a high risk patient, correct? For
Well,
infection.
certainly the literature has suggested that over 40 have an increased risk of infections, wound problems, everything actually, because they don't mobilize as easily.
Hmm.
The problem with a hard number like that is there's a 40 BMI patient who's, for lack of a better term, a fat slob. And you have 40 BMI patients who are rock solid dudes who are just muscular and
Yep.
just they're heavy because it's height and weight. There's no body fat analysis in that, which is
Hmm.
a huge mistake because we mentioned weight loss earlier, and it really isn't necessarily weight loss that improves these people. It's body composition change. More muscle mass, less body fat it ends up being more weight usually.
Done.
But they do
I'm
it really should be a body fat percentage in there somewhere for BMI.
right. No, you're right.
BMI needs to, and this
Question.
is one that will go viral on shorts. And let's have your take, both of you, on BMI. I think it's not a great way to measure things.
It's a
Like
terrible
I
way
go
to
to the
measure.
doctors to say you have an athletic build, and we're not going to look at your weight at all. We see it. You have an athletic build. You don't have much fat on your body, but yet it's muscle, weighs more than fat, so you're carrying a lot of weight. And I
You're
can't.
just big bone.
No, it's from okay. I am my spare tire is almost gone completely in my reverse aging process from when I about 4 years ago, and I've gone through that journey. But I'm like, dude, I can lose weight, but I lose a couple pounds. But I'm not looking at, oh my gosh, I need to lose so much weight so I look like Skeletor. And so I look at all these things, and I said also when I start to do more yoga, strength yoga, I gain weight, but I not gain weight in the wrong way. So I think this
Yeah.
BMI thing needs to be. So what are your thoughts, both of you, on BMI?
Yeah, I would agree. and I'm glad we didn't talk about this earlier, John, and we haven't probably ever had this conversation, in all our years of friendship. But exactly what you say, the patients that you see, that I have so many patients in my head that have BMIs of like 41, but they're former football players. They're very muscular guys. A lot of them are African American. They look in good shape and they've got horrible knees and they would probably do well with a knee replacement, but they don't qualify or they get knocked off. But then you've got these other people, they're like, her BMI came back, it's 34, 36. Like she's those patients to me in my experience are higher risk than the guy who the former football player that's a 41. What would you say on that? You agree?
I agree. I think to Neil's point, BMI is not a great
Mm-mm.
thing to judge on. They use it because it's out there. Height's easy to measure, weight's easy to measure. There's tables available, and so they use it. If they why they don't use body fat percentage, because that's easy to measure in today's day and age. It's a cheap scale you put in your office and it's easy to measure. So I think that they should add that in there somehow. I don't have the statistics to determine what the number should be, but
Right.
certainly it's more valuable to me than height and weight.
No, I agree 100%. And
Risk and outcome.
you get stuck in this situation where some people, for lack of a better term, need a knee replacement. First of all, I don't think anyone needs a knee replacement. I think it's still an elective procedure. It's something you want. There are other options, but some people get to the point where, they've failed non-surgical care and they're over the BMI limit. So insurances won't approve it. So those people are, I think, really the very sad cases. They can't get the care. And it's like, what is the other alternative? Putting them in a scooter? They said if
Oh,
you have a choice between getting a knee replacement and going in a scooter for the rest of your life, and it's almost a death sentence. There are some patients that are at that. It really pulls at your heartstrings with them. You're like, I can't do the knee replacement. You don't qualify. You got to lose the weight, and it's very hard for them to lose the weight.
now you're going down a road of the Wegovy's and the semaglutides and the
Hmm.
different weight loss, which are effective. I mean, they are
Yeah.
no question they are effective. If you can get them approved, people lose weight.
And then and
That's a
then
whole different
gastric
problem.
and then gastric bypass. So you're adding
It ended
another.
up being a terrible operation, in my experience.
Yeah.
People, you can't undo it. You
No.
can go on Wegovy or Ozempic, lose whatever you have to lose, have your surgery, come back off of it. Hopefully
Hmm.
you improved your lifestyle, you've improved your eating habits, and improved the secondary things which are healthy for you,
Hmm.
and you come off of it, you're done.
Yeah.
You can't
And you
undo a
can get
gastric
a, you can
bypass.
get their
Never the
exact. Yeah, exactly. You can get their weight down with those semaglutides. Um, GLP-1 agonists,
right.
but they also lose muscle mass, some of these patients. There's a muscle mass loss, and you need the
Sure.
muscle for the surgery and for health and for balance and for longevity. You know what I mean? So it's
Right.
there's no
It's like
there's no
some of the
utopia, John.
insurance covers. Unfortunately, it's an insurance game. Like you're
Hmm.
41, you can't have surgery. You're 39 and a half, you can have surgery. That's
And you're right, the physician judgment unfortunately has been taken out of that
right. Yeah,
that
and they'll say
formula.
we don't practice medicine. You can do the surgery, we just won't pay for it. Patients can't afford it, so
Yeah.
Exactly.
Yeah.
All right. So, I mean, Jack, we've had a great conversation. I think that BMI thing is going to definitely get people going, especially in the medical field. Where do you think the best thing when how focusing on a knee replacement? I'm going to ask that last question. What's that measure, that marker that you definitely need a knee replacement?
Yeah, I think in my opinion, I would say John's the same. We treat, I think we're trained very similarly. It's when you get to the point where your knee tells you that you need a knee replacement. You've done everything else. And what I would say, I said with the men's clinic, I do think for men, I think the possibility of testosterone replacement, I think it's worth taking a look. If they've got a low testosterone, if you get them on supplementation, you can maybe get rid of some of that belly fat. You can maybe improve some muscle strength and their knee pain may go down. These are things that are you need 100 patients and do a study on it, which doesn't necessarily exist. But like I say, personally, and some of the stuff that I've seen with friends and colleagues, um, by improving your muscle mass, by reducing your belly fat, um, you're putting less strain on your knee. So just naturally, you're going to have less knee pain. So for that 40 to 50-year-old patient who doesn't, 55, 60-year-old patient who's not quite ready for a knee replacement, their knees aren't that bad, but they're still miserable. I think to, check their testosterone wouldn't hurt. Consider supplementation. It may certainly help. What do you think about that, John?
I agree with you. To answer Neil's question more directly, you consider knee replacement when the pain in your knee affects your lifestyle and the ability to do your activities that you want to do, whether it's run, bike, walk, play with your grandkids, walk your dog, whatever it is that you want to do, you can't do it anymore because your knee hurts you so much, and you have knee arthritis, and you failed other things, the injections, the anti-inflammatories.
Mm-hmm.
That's the time to consider knee replacement. Now, Jack's point about the testosterone replacement or optimization really is very valid, whether you need a knee replacement or not. If it can help you avoid a knee replacement or postpone a knee replacement, great, right? Even if you're going to have a knee replacement, optimizing your testosterone will help you optimize your rehab afterwards, your prehab beforehand, and really your total outcome after a joint replacement. There's no question
Mm-hmm.
about it, especially a hip or a knee.
Yeah, actually, one of my patients, that you mentioned that a patient of mine was going for a hip replacement, and we got him on testosterone beforehand. And he's like, I mean, hip replacements, they do have a good recovery, but he swears that his recovery was really enhanced by testosterone. He goes, yeah, I feel great. I've got some strength. I did rehab fine. He goes, it didn't give me a problem at all. So, it's nothing you're going to find in the mainstream that says, yeah, testosterone, there probably needs to be more studies on it, but it's
Right,
an option. Like I said, if you're trying to avoid surgery, there are worse options that you could consider.
right, right.
So, what else, John?
Great stuff. That's all I have to say.
Yeah, I think it's an interesting topic, and I think my view on it so when we trained, we were the carpenters. You have a knee, it's
Right,
arthritic, you replace it. You know, um,
right,
but as you mature, as you become a little wiser, as have some experiences behind under your belt, you're like, you know what? The spidey senses start talking to you and say, you may not be the best candidate for a knee replacement. Let's try some other things. And you're never wrong trying other things as long as the patient is willing and able, because there are many different options besides just jump to a knee replacement that can help.
right.
You made that
Well, you
great
have to
point in the beginning. We're there to help people
expand your
reduce
practice.
their
You're there to
pain.
help the patient.
Right. We're not there to replace their knee. If replacing their knee is what they need, well, then that's what they need. But if something else is what they need, we have to consider both options.
Correct.
Absolutely.
Well,
All
thank you.
right. So, best place to go, John, just look him up. Jack, go to theultimatemensclinic.com in New Bedford, Massachusetts. Appreciate it, guys. Thanks again and great stuff.
Thank you, guys.
All right.
Both
That's a
of you.
special
Thanks.
simulcast of the Neil Haley